Like if you don't have, yeah.
So, do you have the slides on your canvas?
Oh, let me check.
Okay.
This is
BRONJ. Oh, so you don't have it? You don't have it. I will send it to you. Okay. Thank you.
Yeah. Okay.
Okay. I think you have it. Okay, good morning, everybody. Sorry, can you hear me okay in the back? Can you hear me?
It's the speaker's over there.
Oh, really? Okay, so let's see. No? Hello? Oh, is it good? Okay. Okay, that's great. I just brought this microphone from that side, so that's why, probably. Okay, so I think you all have the slides for bisphosphonate-related osteonecrosis of the jaw. I just sent it to you. Sorry, I didn't send it before this. So we have a very short session on BRONJ, and then after that we have the review session, or do you call it BRONJ? Is that right? In dentistry, I think it's BRONJ. Oh, okay. But in pharmacy we say BRONJ. So, okay. So let's talk about bisphosphonates a little bit, the mechanism of action. So what's important for you to know is how they work. These medications, for the most part, they inhibit osteoclasts. And as you know, osteoclasts are responsible. There are cells in the bone that they are responsible for what? Do you remember? Osteoclasts responsible? Bone resorption. Very good. So if we inhibit them, it means the bone is not going through resorption. We slow down the process. So that's very important mechanism of action for bisphosphonates. The other thing is they increase the bone mineral density. The reason for that is when you slow down the resorption, calcium stays there in the bone structure. So the bone density goes up. There are also analogs for inorganic pyrophosphate. Pyrophosphates are a part of bone structure. They are a part of a structure to hold calcium inside the bone. And they have very high affinity to bind to hydroxyapatite crystal. Again, these are all structures of the bone. So these medications, we take them orally or by injection, but the point is they get absorbed to the bone. And when they get absorbed to the bone, they stay there for a long, long time. They just bind to the bone structure and stay there. Okay, in regards to the PK, their bioavailability, oral bioavailability, is very, very low. So if somebody takes bisphosphonates orally, a very, very small amount of that get absorbed to systemic bloodstream. The rest get excreted, and almost 80-90% of the medication get excreted and get cleared out of the body. Very, very interesting and important fact about pharmacokinetics of this medication is the plasma half-life is 1 hour. So the half-life in the blood is very, very short. But as soon as they bind to bone structure, they get to the bone, they stay for years, for up to 10 years. This is very, very important for you to know. Because just by looking at the PK, oh, I'm sorry, actually we are this side today. The AB, that side didn't work, so we had to move. So the plasma half-life is short, but when they get to the bone, they stay for years. And that's important. Why? Tell me why it's important to you.
Because they don't have bone resorption, so
They don't have?
like it affects the bone resorption.
They affect the bone resorption. But why this long half-life would be important to you?
Their effects last longer, like interactions.
Very good. The effects last longer. So let's say if you worry about BRONJ, if you worry about bisphosphonate-induced osteonecrosis of the jaw, and the patient has, let's say, extraction or traumatic dental procedure, and the dentist decides to discontinue bisphosphonates 2 weeks prior to the procedure, do you think it helps? No. 2 months? No. 6 months, even a year, probably does not help. But when we go to next slide, you see that the incidence of osteonecrosis of the jaw due to bisphosphonates is not that high. So we shouldn't worry that much, but discontinuation of medication is not necessarily a solution. And the only reason is when they get to the bone, they stay there. So it takes years to be clear from the body. Okay, this slide, don't worry. Let's go to next slide. IV and PO bisphosphonate. The reason I brought it here is it's very important for you. When patients are worried about osteonecrosis, it's important to see if they are on IV versus PO. In general, being on PO bisphosphonate, because of low bioavailability, we shouldn't be worried that much. Usually, PO bisphosphonates have less effect on bone structure than IV bisphosphonate. And the other thing is, usually when we see IV bisphosphonates, we see them in cancer patients. Not all the time, but because sometimes you see IV bisphosphonates to be used for osteoporosis. But if they are used for cancer patients, they have other risk factors that cause osteonecrosis. With bisphosphonate, it's even worse. So it's very important to evaluate the case. If the case is an osteoporosis case, usually the incidence is very, very low. Especially with PO medication, the incidence is even lower. When we talk about IV medications, IV bisphosphonates like zoledronic acid or pamidronate, the incidence of the problem goes higher. And when we talk about cancer patients, multiple myeloma, metastatic breast cancer, metastatic prostate cancer, then the risk is higher. So in the exam, please pay attention to that. So in this picture, I think we had it before. Do you remember where we had this slide?
With thyroid.
Thyroid? No. You mean parathyroid? No. When we talked about steroids, we had this slide. Because when we are talking about bone structure, there are some medications that help bone structure. They prevent resorption. There are some medications that they help resorption, which is not good. So when you're talking about steroids, like prednisone, methylprednisolone, they help resorption, which is not good. When we are talking about testosterone, estrogen, or bisphosphonates, we are talking about medications that help building the bone. So if you look at the picture, you can see, for example, bisphosphonates. If you look at that green circle on the top, aminobisphosphonate, they have negative effect on osteoclast. So they prevent bone resorption. But if you think about steroids, they help resorption, which is not necessarily good. Okay, indications of these medications is very important for you to know. So indications are either osteoporosis for treatment or prophylaxis purposes. or metastatic bone disease and or hypercalcemia. So the last two bullets, you see them in cancer patients. Many cancer patients, especially when we are talking about metastatic cancer patients, we are talking about hypercalcemia. So the serum calcium goes higher. So we have to use these medications to suppress bone resorption to bring calcium down or lower. And also in metastatic bone disease, in order to prevent the damage to the bone, in order to prevent excessive resorption and pain, we also use bisphosphonates. So it's pretty common to see these medications in patients with metastatic cancer. Okay, in regards to the use for osteoporosis, look at the two medications. Please remember these two. There are other medications that may cause osteoporosis, but these two, corticosteroids or steroids in general, glucocorticoids, the other name for steroids, and heparin. Do you remember what was heparin? Anti-blood thinner or anticoagulant. So some patients have high risk for blood clot, and we have to put them on heparin for long term, for months or even years. So those patients have higher risk to develop osteoporosis. So let's say if a patient in 20s or 30s is on heparin for months or years, he or she is more prone to develop osteoporosis in much younger age, like in 40s. So we have to be very careful about that. The same with the steroids. Some patients have autoimmune disease or inflammatory diseases that we have to put them on a steroid for long term. So we have to be very careful and watch them. We have to put them on calcium and vitamin D supplement to slow down the process and delay osteoporosis. There are other medications. Do you remember any other medication for your exam? Anti-epileptic medications, do you remember? Some of them, like phenytoin, the inducers, the cytochrome P450 inducers, because they induce vitamin D metabolism, so we need to give the patient vitamin D and calcium, because they affect vitamin D, so they affect calcium absorption, they increase the risk of osteoporosis. So there are much more medication. I just want you to remember some of them, because when you see patients on these medications or these classes, then at least what we can do is ask patients to be on supplemental vitamin D and calcium, if there is no contraindication for that. Okay, I'm not going to ask a question about this slide, but this is a fact that I believe as healthcare professional we all need to know, that it's a evidence-based practice that bisphosphonates, most of them, they prevent the fracture of hip and vertebrae. So it's very, very important, especially around menopause age, for patients to be started on bisphosphonates. Because again, it delays the bone resorption, excessive bone resorption and fractures. And just for your information, the majority of evidence is supportive for alendronate and residuronate. Because you may have heard about Boniva, which is ibandronate, like 1 tablet every month or 1 injection every 3 months. Boniva or ibandronate doesn't necessarily prevent hip fracture. And hip fracture is very important. So when you think about bisphosphonates, these two are, and zoledronic acid, are very effective in order to prevent hip fracture. In regards to metastatic bone disease, it's either just bone disease like piaget disease, or it's due to metastatic cancer. So it involves the bone structure. So what we are talking here is bone resorption. Because cancer gets to the bone, it causes bone resorption. The serum calcium goes up, and the calcium in the bone goes lower. The calcium reserve in the bone goes lower. So bone is more prone to fracture. So that's not good. That's one of the reasons we want the patient on chemotherapy, long-term chemotherapy, to be also on bisphosphonates. Okay, don't worry about those interleukin, prostaglandin, TNF. For the most part, I want you to focus on, if you think about chemotherapy, if you think about cancer, and especially if you think about metastatic cancer, think about bone resorption. And that's why we need to see the patient on bisphosphonates. Okay, let's see here. Okay, on this slide, I just wanted to focus on zoledronic acid. So again, for your exam also, if you see IV zoledronic acid, especially the medication to be used on cancer patients, think about higher risk of BRONJ. I'm not saying that it's very high risk, but the risk is higher. Because you're talking, the patient is taking other medications that may induce damage to the jaw and bone, and also high dose bisphosphonate, more frequent, and IV. So the risk is higher. Okay. So basically, the mechanism behind how bisphosphonates cause osteonecrosis is not very well understood. What we can, basically based on the theory that we have, is they prevent osteoclast activity. So they prevent bone turnover, like natural bone turnover. So bone stays with the same mineral density or even higher, but there is no turnover. And that may cause more, the bone to be more fragile. So that's one theory, that when we have a patient on long-term, especially long-term bisphosphonate, it may cause more fragility of the bone. And also bisphosphonates have some anti-angiogenesis effects. Do you know what is that? Prevent very good. Prevent the formation of blood vessels. So if they have some anti-angiogenesis effect, then they prevent blood vessel formation around the tissue, including mandibular tissue, and it causes more problem. Okay, this slide, it's very important, especially the second and third bullet. Look at the incidence. Overall incidence of, let's say, 1 to 12% if intravenous bisphosphonate used in cancer patients. So 1 to 12%. 1 to 12%, it's because the dose is different, the frequency is different, and patients on chemotherapy may receive different medications or radiation. So if patient is receiving radiation, the risk is higher. If the patient is on higher dose of some chemotherapeutic agents, the risk is higher. And if the patient is on higher dose of bisphosphonates, IV, more frequent, the risk is higher. So that's very important. Look at the third bullet. The risk for oral medication is much lower, less than 1%. So if the patient is taking bisphosphonates just for osteoporosis prevention or treatment, oral medication, or even IV, but with very long frequency, they should be okay for the most part. And then major risk factors, very important for you as dental professionals. Look at the risk factors: trauma or invasive dental and periodontal procedures. Tooth extraction. Extraction is a big one. So the patient may be good until they get like a traumatic procedure like extraction. And then the whole destroying process gets started. So that's very important to induce trauma. Infection, of course. Infection causes abscess, cause inflammation, so it may initiate the problem. And duration of bisphosphonate, very, very important. If the patient is on alendronate for 6 months versus the patient is on alendronate for 5 years or 10 years, that's why in medicine we usually give patients some medication holiday or drug holiday. So they are on bisphosphonates for 10 years, and then after that, we give them a few years off medication, just to not overload the patient with medication. And when the medication is in the bone structure, they stay there. They stay there for a long time. So we don't need to keep giving the patient the drug. Also, type of bisphosphonate. Again, IV versus PO. That's one of the most important factors that, of course, with IV, we have higher risk of the issue. These are just some pictures I found, and radiographic picture. So I can see that. I think it's more obvious for you, the necrotic tissue. And especially if you look at it's mandible, because the blood supply, is it right? In mandible, we have lower blood supply than in maxilla, right? No? Okay, don't worry about it. But it's more often in mandible rather than maxilla. And I think the problem is with like the vasculature. I believe in upper jaw we have more vasculature, so less problem with upper, rather compared to lower jaw. Stages of BRONJ, it's like from like exposure of the tissue, like the bone structure, or beneath the gingival tissue structure, and then infection, inflammation, and necrosis. So I'm not going to ask a specific question from this slide. This is just a kind of natural process of the disease. So from inflammation, superficial inflammation, up to deep necrosis. So in some cases, in severe cases, the surgeons, oral surgeons, may need to remove the bone and the tissue, the necrotic tissue, like debride it. Risk factors are very important. The reason it's important for you to know is some patients may come to you and say, you know what, actually I'm on alendronate for osteoporosis. Am I in high risk of developing BRONJ? Not necessarily, because look at the risk factors. First of all, we talked about the dose and the frequency, and also if it's IV or PO. The other thing is, if the patient is cancer patient, then the patient may receive other treatment or other medications, radiations, that those may affect the bone structure, not necessarily bisphosphonates. A big factor would be head and neck radiation. So if a patient, due to a specific cancer, they need to receive head and neck radiation, the risk is much higher. Because radiation by itself induces a lot of damage to the bone structure and also the blood supply. Use of corticosteroids. So if the person is on a steroid for any reason, especially higher doses, longer term, we are talking about damage to the bone anyway. It's not just because of bisphosphonate. It can be other medication. Use of other anti-angiogenesis medications. So bisphosphonates prevent the formation of blood supply or blood vasculature around the tissue. There are other medications, a lot of other chemotherapeutic agents. We use them in colon cancer or lung cancer. They may also prevent the formation of blood vessels. So if the patient is on both at the same time, of course, the risk is higher. Okay, look at the very last bullet, more common in mandible than in maxilla. So if you look at the ratio, it's almost twice in mandible. So more issue with lower jaw. What we can do to prevent it? Basically, the most important thing is patient to be visited by dental hygienist or dentist. Especially if you are talking about patients who are going to have chemotherapy and bisphosphonates due to metastatic cancer disease, we want them to come to you. And you check them first. If there is anything, any procedures you need to perform, you do it first. Or if there is any need for extraction or any traumatic dental procedure, we want it to be done first. And after a few weeks or a couple months, the patient can start to be on high-dose bisphosphonate. This way, the risk of osteonecrosis is much lower. The other factor is more frequent visits. So patients are on bisphosphonates. If you just at least twice or every quarter, you visit them. If there is any inflammation or any sign of tissue exposure or infection, you can catch it earlier. So we can start antibiotic. If debridement is needed, the dentist can perform debridement, and we prevent the like a big necrosis. So like more frequent visit is very, very important. And of course, avoid invasive procedures if the patient is on bisphosphonate. If it's not necessary, we can wait, we wait. But always keep it in mind. What was the percentage? 1% or less. If the patient is taking, let's say, alendronate for osteoporosis. If the patient is taking zoledronic acid IV for multiple myeloma every month or every 3 weeks, then the risk is higher. Okay, keep it in mind. Okay, again, based on bisphosphonate pharmacokinetics, that they go to the bone structure, they stay there. There are some theory that if we wait, if we give the patient drug holiday and wait for good time, at least a few months, and then check the bone markers in the blood, just do the blood test and see if the bone turnover is back into the normal, then we probably are in safer zone. But it's not that much of evidence behind this practice, because we know that bisphosphonate, the effect is long. So even by testing this, which most probably is an expensive test, it's not a good proof that, oh, okay, we are safe or we are not safe. But, you know, there are some studies talking about this. That's why I just mentioned it here. And also, if we can use IV bisphosphonates less frequent, if we can use it less frequent, we do it. But in a lot of cases, again, we cannot use zoledronic acid every 3 months. We have to use it every month. So these are just some ideas to delay the process if possible. If the infection happens, because when the tissue is exposed, then we have infection and inflammation, then antibiotics needed. So just look at the antibiotics, penicillin or beta-lactam family, like amoxicillin, cefixime, they are both beta-lactams, plus or minus metronidazole. And metronidazole in the majority of cases is added. And the reason for that is when we are talking about oral infection, we are talking about anaerobic bacteria. So we give the patient metronidazole to fight anaerobic bacteria. If the patient is allergic to beta-lactams, then levofloxacin or doxycycline can be used. And also chlorhexidine mouthwash may help. Chlorhexidine is an antibiotic, antifungal, and it has pretty good local effect, like topical local effect. So chlorhexidine is also recommended. And finally, surgical debridement. If there's a lot of necrosis, if the infection and necrosis is pretty deep, then the dentist needs to debride the tissue, the necrotic tissue. But for the most part, if it's still superficial, with using antibiotic on the right time, right dose, right duration, we can prevent like the extension or the expansion of the infection. I don't ask any question in this slide. This is just for you to know. Antibiotics and what are the antibiotics that we can use. The very important point one is metronidazole, just for your information. Metronidazole is good for anaerobic infection. That's why a lot of oral infections, you will see the patient to be on metronidazole. Always remember, our first options are beta-lactam plus metronidazole, except if the patient is allergic to beta-lactam. Then doxycycline or fluoroquinolones can be used. So, as the summary, incidence, I think the most important thing for all of us to know is if the patient is concerned about the medication, the incidence is very low. If the patient is under treatment for cancer, especially chemotherapy and radiation, then we need to evaluate other risk factors. If the patient is receiving high-dose chemotherapy or radiation, we have to be very careful. If there is any dental procedure needed to be done, we prefer to have dental procedure first and then start bisphosphonate if possible. If the patient is already on bisphosphonate, I'm talking about cancer patient on high-dose IV bisphosphonate, and there is a kind of elective dental procedure, we can delay it, we prefer to delay it. So it all depends on each individual case. We are good? Okay, great. So let me tell you, probably for the exam, I want you to focus on risk factors and IV versus PO. Which one has higher risk to develop the problem? Okay? Any questions? Did you have this topic in other course? Okay. Which course? Oh, okay. Next hour? Do you have quiz on this? Okay. Oh.
We have one. Something else.
Oh, but not on this topic. Okay. So, if there is no question, let's go to study guide. If you go to your canvas and have all the slides, so when I'm talking about topic to topic, you have the slides. So if you want to write a note or mark the slides, it's maybe easier for you. Okay, I'm talking about GI. So can you bring the GI slides? On the GI slides, if you remember, we talked about GERD, reflux disease. I want you to know all treatment options for GERD, reflux disease. You remember we talked about antacids, we talked about PPIs, we talked about H2R blockers. So remember the names, remember which one has faster effect and shorter effect, which one has a longer effect and is slower, of course. Yeah. So you have them PPIs, longer, slower, antacids, faster and shorter. Know the adverse drug reaction. If I mention anything in a specific, especially in your slides, remember the adverse drug reaction. Remember drug-drug interactions. You remember when we were talking about antacids, they may bind to other medications. They have chelating effect. They prevent the absorption. You're okay?
Oh yeah. So we're still talking about GERD when you say no?
Yes.
adverse drug reaction?
Yes. For the most part, on GI section, focus on GERD. Medications, adverse drug reactions, drug-drug interactions, and of course names. And the onset of action, big one. Okay, in regards to nausea and vomiting, I just want you to know the classes in general. Can you name the classes that we use to prevent or treat nausea and vomiting? Which classes?
Serotonin, epinephrine,
Serotonin agonist or antagonist? Antagonist. Very good. Like what? Very good. Very good. Cetrons in general. So in the exam, you may not see ondansetron. If you see granisetron, medications, antiserotonergic medication, pick that one. Other classes that we use in nausea and vomiting, antihistamines, antidopaminergic medications, these are all used in nausea and vomiting. So please know which classes and which medications. So I may ask you antiserotonergic, antidopamine, antihistamine, or I may give you the name of the medications. So if you know which medication is in which class, you can pick them. The answer can be all of above. Because if I give you antihistamine and antiserotonergic, then both of them are right. Is that right? Okay. Are you tired? This is Thursday morning.
We're always tired.
You're always tired.
I know.
This is end of the quarter, so it's good.
I'm a week before we
Okay. In regards to constipation, no different classes that we use to treat constipation. And please know which one works faster, which one works slower. Take time. So when we are talking about stool softeners, they are pretty slow. Versus when you're talking about osmotic medication or stimulants, they work pretty fast. So please know, this is the list I want you to know. Different classes we use in constipation and the name of medication. So I give you a medication and I ask you, how does it work? Is it a stool softener? Is it a stimulant? How does it work? Okay. Anxiolytics. Very, very important point about anxiolytics. If you want to bring the slides. You're good? Okay. Very important point is the onset of action, again, because this is important for you. When the medication starts working and how long does it take? So if I give the patient diazepam versus midazolam versus teriazolam, which one works faster and which one the patient go home and the patient is okay, versus which one the patient goes home and the patient is sleepy for the rest of the day or the next day. So this is very important. I want you to know that. The second thing is, remember when we were talking about benzodiazepines or antihistamines or nitrous oxide, we were talking about which one causes anterograde amnesia, which one causes sedation, which one has analgesic effect. Know that. Question?
Which one's the fastest anxiolytic? Is it midazolam or trazolam?
Okay, midazolam is the fastest. So if in the question I give you both midazolam and teriazolam, midazolam is the fastest. But I usually don't give both of them in the same question. So if you have midazolam, lorazepam, diazepam, very good peace of mind, you pick midazolam as fastest one. If I give you diazepam, midazolam, and teriazolam, I usually ask for the longer effect or delayed onset of action, which is diazepam. So I don't want to mislead you and give you two medications that are very close in regards to onset of action. I give you the choices that the difference is pretty significant.
The mic went on.
Oh, the battery.
Yes.
Oh, you know what? Let me see. This is for the other room, so let's change it.
Take them.
Maybe it's ethically not good, but
Don't say that. Don't say that.
I didn't see any.
good.
You know, I pay no attention.
Okay. Is it good? Okay, great. So please, again, for anxiolytics, know which one is faster, which one takes longer time to start, and also which one, for example, nitrous oxide, it's anxiolytic, causes anterograde amnesia, causes sedation, versus benzodiazepines, they cause anterograde amnesia, they cause sedation, they are anxiolytic, but they are not analgesic. That's very important. We never use diazepam to treat the pain. We never do that. In fact, if the patient is in pain and we give the patient benzodiazepine without painkillers, we make it worse. So it's very, very important that we do not use them for pain. Okay, so that's it for anxiolytics. Okay? Seizure, antiepileptic medication. Very, very important to know which ones are inducers, which ones are inhibitors. Okay? That was one of the focus of the session. Inducers and inhibitors. Why? Because drug-drug interaction. Because they affect other medications, metabolism. The inducers, if you remember, they cause osteoporosis because they induce the metabolism of vitamin D. So I want you to know them. Very important, a good question for the test. Which medication is autoinducer? Which one? Carbamazepine. Very good. Very good. Please remember that. It's good for your board exam also. Know the adverse drug reactions in general. All those are important. Adverse drug reactions. So when we are talking about vigabatrin, do you remember what was the major adverse drug reaction? Blindness. It's very important because it may happen 30% of the time. That's why vigabatrin is the last resort option, only for refractory cases. So please know the effect on metabolism, inducers, inhibitors, and adverse drug reaction. Okay, anticoagulation and antiplatelets. Know which medications, IV or PO, doesn't matter, which medication they need to be dose adjusted for renal function. I specifically mentioned which medication are safe even in patients with renal insufficiency. Do you remember those? Which anticoagulants are safe to be used in patients with CKD or renal insufficiency?
Heparin.
Heparin?
Wait, which one is this?
Sorry. We are talking about anticoagulants.
It's
Anticoagulants.
Is it on the same lecture?
it's a
No, no.
bath.
No, anticoagulants is different. Anticoagulants, sorry, I should tell you. Anticoagulants and antiplatelets. Heparin and warfarin. We don't need to adjust the dose. Others, we need to adjust the dose. All those Exavans, enoxaparin, other medications, you need to adjust the dose. So that's very important fact to know. Miss President, are you okay? Okay. Good. And then antiplatelets. Remember, I mentioned specifically if the patient is on dual antiplatelet therapy, so the patient is on aspirin and clopidogrel, there is a very important reason for that. The patient has a stent placement surgery or procedure. So you never want to discontinue them for dental procedure. So if the patient comes for extraction or any other dental procedure, we keep them on board. So if the patient is on clopidogrel and aspirin, we do not discontinue them. If the dental procedure or like deep cleaning, you expect heavy bleeding, delay the dental procedure. Because usually those patients are on dual treatment for 9 or at most 12 months. So if you can delay the procedure, you do that. If not, just do that without discontinuation of medication. Know the antidotes. Antidotes are very important. So if I talk about any antidotes like vitamin K, I talk about protamine for heparin or other antidotes, please remember them. Other thing I want you to remember is, okay, let's see. Oh, in case of the dental procedure is there and we don't want to discontinue anticoagulant or antiplatelet, there were a couple topical medications that we can use to prevent bleeding. Remember those. Tranexamic acid.
Can you repeat that one?
Oh yeah, so there are some topical medications that we can use during the dental procedure. It was toward the last slide. To prevent bleeding. So remember those. Aminocaproic and tranexamic acid. Did you find it, the slide? Okay. Okay, talking about pain and analgesics, very, very important part is when we are talking about NSAIDs. We know like the pharmacologic effect. We know that they are anti-inflammatory. They are analgesics. They are antipyretics. They have sealing effect, and patients doesn't start to be tolerant or to the analgesic effect. So as long as the patient takes the medication, they are okay. They don't develop tolerance. Acetaminophen the same, except for anti-inflammatory effect. Acetaminophen doesn't have anti-inflammatory effect. It's antipyretic, It's analgesic, has sealing effect, but no anti-inflammatory. Please know the max doses, the ones that I mentioned, especially for naproxen, ibuprofen, and acetaminophen. Know the max doses,
Or which one?
acetaminophen, ibuprofen, and naproxen.
Acetaminophen, ibuprofen.
Naproxen, naproxen,
Okay.
okay? So what's the max dose of naproxen per day? How much? 1500, very good, 1500 milligram. How about ibuprofen?
3200.
3200 milligram. And how about acetaminophen? 4 grams, 4000 milligram or 4 grams. So please know these numbers because this is important again. I just don't want to ask this for the test. Definitely the questions is in the test. But at the same time, it's important for you to know because patients can go to the pharmacy and just buy the medications. And they can easily get overdose. Now, the second question in the test about the dose. If the patient accidentally gets overdose, what's the issue with NSAIDs? Kidney and GI. Very important. The patient gets GI bleed or kidney damage. What was the issue with acetaminophen overdose? Liver. Acute liver toxicity. So, very important. Please know that. I can tell you a lot of pain questions. So, pain lecture,
Just pass the exam.
make sure, yeah,
Take a picture.
I can put that on the screen. You are all good, I'm sure.
A lot of pain questions? So a lot means like a fifth of the test?
Like half, 4.
Let's just go over just say a lot of pain questions. And the reason for that, it's not just I like pain medications because it's important for you. Because you have patients on these medications. Okay, opioids. Do you remember adverse drug reactions? Like constipation, pruritus, respiratory depression. Please know which one the patient does not develop tolerance. Constipation. Very good. So you're already ready for the test. I like it. And also know the potency. Like if I give you the list of either combination of opioids with acetaminophen or just opioids by themselves. Let's say morphine, hydrocodone, codeine, or oxycodone. Which one is more potent? I want you to know which one is more potent. Oh, somebody is recording. It's okay though. That's fine. Recording is good.
That was fun.
That was a phone. Okay. In regards to pain again, focus on migraine. Migraine headache, acute pain treatment versus prophylaxis. Please remember the list of medications that I gave you to be used as prophylaxis. So know them. It can be any of those in the exam because there are a number of them. And also know the medications to be used for acute migraine pain. Okay, know the difference. You remember which medications we can use for acute pain? Triptans, very good. What else? Very good. Ergotamine, or possibly NSAIDs. So we can use them. Or NSAID with acetaminophen with caffeine, if the patient is not allergic to caffeine. Okay? Chemotherapy. Know the classes and the medications. Okay, so let's go to chemotherapy slides. When you're ready. You're ready? Okay. On chemotherapy slides, please remember there was one slide I was talking about adjuvant treatment versus neoadjuvant treatment. So chemotherapy before surgery, chemotherapy after surgery. Know that slide very well. I can tell you, there can be a question on that slide. Second thing, please know the names and classes. So antimetabolites, versus alkylating agents versus topoisomerase inhibitors. Know the agents. Which medication may cause cardiotoxicity? We had 1 or 2 slides about cardiotoxicity, which was a heart failure. And we were talking about doxorubicin and daunorubicin. So please know that. Also know mucositis. Very, very important for you because patients come to you with mucositis. Know the medications or the cocktail that we use to treat mucositis, like antifungals, local anesthetics, like viscous lidocaine, and other medications. Just if I give you the medication and if I ask you which of the following can be used to treat or prevent mucositis, you can recognize the medications. It can be more than one. Okay? No other major toxicities, like nephrotox. Oh, question.
Were you still going to go over the first 2 exams?
The first 2 exams,
Like the test questions?
yeah, the thing is, if you wanted to do that, you can come to my office. But basically, I'm doing it right now. The questions that are important and are repeating, I'm reviewing them right now. But by any chance, if you need to review your first and second exam, you can come to my office this afternoon. Tomorrow, I'm not on campus. Question?
Can you say one more time mucositis?
Sorry, what's that?
Can you say one more time about the mucositis part?
Oh, mucositis. Okay, I just wanted to know which medications we can use to treat mucositis. There was 1 or 2 or 3 slides, I believe. I was talking about different medications can be used in mucositis. Just remember all those medications. Okay, so if I ask you which medication may cause hemorrhagic cystitis, I want you to answer. Which medication may cause nephrotoxicity? Answer. Cardiotoxicity, because they were 1 or 2 medication in each of toxicity category.
Can you repeat that, please?
Yeah, the toxicities.
Cardiac,
Yeah, you know what? I think I'm specific enough on the topics. So I'm talking about toxicities. So know which medication caused which toxicity. Okay, you need to read the slides and find those. Is the microphone okay?
Yes.
Can you hear me?
Yes.
Okay, good. Know the antidotes. And let me tell you, one of the most important antidotes that I want you to remember is leucovorin for methotrexate. Because you will see that all the time. Patients be on oral or IV leucovorin if they are taking methotrexate. So remember that one, if you want to remember one antidote for anti-neoplastic agents. Okay. In regards to the treatments, let's say anemia, low white count, and low platelet. There was 1 slide that I was talking about medications to treat those. Anemia, neutropenia, and low platelet. Know those 3 medications. Did you find the slide? Okay. You will find it. Yeah.
How many questions are you heading for?
50.
Oh,
50 questions. So 50 questions for 50 points. OTC. For over-the-counter medications, we talked about acne, we talked about wart, we talked about cold sore. Please know the medications, like benzoyl peroxide. What kind of medication is it? Is it antibiotic? Is it antiviral medication? What kind of medication is it? If I mention any specific adverse drug reaction, please know that. One very important question would be concentration. I specifically mentioned that which concentrations are safe for benzoyl peroxide. So if I wanted to focus more, benzoyl peroxide, salicylic acid, cryotherapy, and treatment for cold sore. Please remember those. When we are talking about supplements, I want you to remember calcium supplements and magnesium supplements, the major adverse drug reaction. So if the patient is taking calcium supplements, what would be the major adverse drug reaction? Constipation. Easy to remember. If the patient is taking magnesium supplements, what would be the major adverse drug reaction? Diarrhea, the opposite. Very good. And then know, when we are talking about calcium supplements, which one has more elemental calcium? Calcium carbonate. So there was one slide that I specifically mentioned which calcium salt has higher elemental calcium. Please know that. Are you good?
A little scared.
No, actually it's easy. Seriously, you know what I just talked about? That's it. That's here. So just focus on those. Okay? Talking about arthritis supplements, do you remember which medications were among arthritis supplements? Chondroitin, glucosamine, SAMe, and MSM. Know which one is effective, which one is evidence-based. First of all of them are supplements, so we cannot say one is definitely effective or not. These are supplements. But if there is one, it's glucosamine. The ones that are definitely know that there is no solid evidence behind them are chondroitin and MSM. For BRONJ, I already tell you which one to focus on. First of all, know which one is IV, which one is PO, and which one has higher risk to induce osteonecrosis. And also the other risk factors. If the patient is on chemotherapy, if the patient is on head and neck radiation. That slide, please. Any questions? Back to your question about the first two exams. With this review, I already reviewed some of the questions. But if you want to go over them, you can come to my office this afternoon. After 3 to 5.
Where's your office?
Shryock building. You know Shryock? The white building. When you go towards Centennial, the parking, on your left side, there is, after the fountain, not fountain, the pool. Yes, the other side of Evans. Yeah. Second floor, room 215. Question.
Is there a possibility that we could get a couple extra credit questions?
Extra credit question? No. And the reason for that is, honestly, if you follow what I just told you today, you are getting at least 90%. By the way, I wanted to ask you, Ms. President, do we have extra credit for attendance or evaluation?
Oh, yeah, 1%.
1% for evaluation?
It's built in, it's not extra.
Yeah.
It's built in?
Like the first quarter, it was like an extra, but now it's like built in.
So, for example, if you get 90%, if your overall grade is 90%?
No, the 91.
It brings you to
Oh, okay.
91.
So it just auto-calculated? Oh,
So if you have a 90 and you don't do the eval, you have an 89%.
okay. No, but I wanted to know, should I add the 1% or it's... I will ask fifth floor to make sure. But you should be okay. Seriously, you don't need extra credit. I can tell you. If you have any questions, send me an email. So if you read this material and it's still not clear, a part is not clear to you, send me an email anytime during the weekend, day or night. I usually answer the emails within an hour or so. Good.
Will you still post the study guide too?
Actually, this was a study guide.
Just
The
more,
point.
in case I forgot something or didn't do something.
Actually, it was a pretty detailed study guide.
I think it was great.
So this was a study guide.
Naveen.
You're good. I'm confident you're good. You're all good. If you have questions, just contact me. It was a pleasure teaching to your class. You were all very, very smart, very professional. It was really a pleasure for me. I wish you the best. I see you next year though. But good luck with your exams, and I'm sure you all get 85% or above in this one. So be good. Take care. Thank you. Thank you. Thank you.
Thank you so much. It was really nice meeting you.
Oh, thank you.
You're
Thank you very
amazing.
much. Thank you.
You motivated us more than we were.
Oh, thank you very much. So, do you need to stay in this room, or you have to?
We leave, right?
Oh, okay.
Yeah,
Sabrina, I just this. Back there.